will occupy some time, which we don't have a lot of today. My name is Nikolai Podoltsev. I'm Associate Professor in Department of Medicine, Hematology section, and I'm joined by Dr. Amer Zeidan and Dr. Lourdes Mendez. Today we will be talking about myeloid malignancies and acute leukemias. I will start by talking about ASH presentations I have selected on the topic of myeloproliferative neoplasms. Amer will continue and will discuss MDS abstracts, and finally Lourdes will finish this session by discussion of studies which were presented on the subject of acute myeloid leukemia and ALL. So without further ado, I will proceed with my presentation. Those who are joining late will be able to get benefit anyway, because this presentation is structured and includes quite a few things. So hold on one second. Let me just see. Here we go. This are my disclosures. So I'm going to talk about four different presentations on the subject of myelofibrosis, and then I will finish with polycythemia vera. It is interesting how many drugs are being developed in the area of myelofibrosis, taking into consideration relatively low prevalence of the disease. In the United States, at any given time, we have about 13,000 patients. Of course, PVera is much more prevalent because these patients survive a bit longer, so maybe 10 times more. So, but of course, development of these new drugs are benefiting our patients. And today I will be talking about four different medications in different stages of development. And just want to say that none of them are approved by FDA in myelofibrosis at this time. And, some of them are in the pipeline closer to be approved. Others is just at the beginning in phase 1 development. So this is the table which summarizes currently approved drugs, which are JAK inhibitors, as well as the drug which is in the pipeline for approval. New drug application was submitted by the company developing this drug to the FDA. This is momelotinib, the last in the table. And the review is expected to end sometime at the beginning of summer. So very soon we'll know if this drug is going to be approved, and it is expected to be. So these drugs called JAK inhibitors, but they actually have slightly different mechanism of action, and that's why they may have slightly different effectiveness as well as different side effects. Ruxolitinib was approved in 2011, more than 10 years ago, and it is JAK1, JAK2 inhibitor used in frontline treatment for high-risk patients with myelofibrosis, intermediate and high-risk patients, with main side effects related to cytopenias. Fedratinib followed in 2019, 8 years later, and this is the drug which can be used in frontline, but most of us are using it in second line. And it inhibits JAK2, but also JAK1 and some other tyrosine kinase, including FLT3, and hence GI side effects. Pacritinib approval was in February of 2022 for patients with myelofibrosis who have low platelet count, less than 50. But in second line, NCCN recommends to use it for patients with any platelet count. Again, GI side effects can be seen in patients using this drug. Finally, momelotinib claims fame in the area of anemia, which is one of the common manifestations of myelofibrosis. And mostly it is expected to be beneficial for patients with myelofibrosis who have anemia because of its inhibition, not only of JAK2, JAK1, but ACVR. In fact, inhibition of JAK2 leads to anemia, and ACVR inhibition actually is beneficial for anemia. So this is the study momentum, phase 3 study of momelotinib versus danazol in symptomatic patients with anemia who have intermediate or high-risk myelofibrosis and previously treated with JAK inhibitors. So these are the patients mostly treated with ruxolitinib who then either were resistant or refractory to this drug and proceeded with a second-line treatment, which included momelotinib or danazol in this randomized study. So as I've mentioned, momelotinib inhibits JAK1, JAK2, similar to ruxolitinib, but also ACVR1, which is activin A receptor type 1. And signaling in ACVR1 leads to increased production of hepcidin, which limits access to iron for hematopoiesis, and inhibition of ACVR1 actually decreases hepcidin and improves production of red blood cells. As the result, it is expected that anemia can improve. So the phase 3 trial looked at patients who are JAK experienced and those who are symptomatic, as well as an intermediate to high risk disease based on DIPSS and have hemoglobin less than 10. So all of these patients are anemic to a certain degree, and platelet count should be more than 25,000. So the study randomized patients in 2-to-1 fashion, and the first group received momelotinib, 200 milligrams per day versus and danazol placebo. The group with danazol received danazol 300 milligrams twice a day and momelotinib placebo. So the key primary endpoint was total symptom score response at week 24, secondary endpoints transfusion independence at week 24, and splenic response rate at week 24. This is the results which were presented at ASH 2022. So this the top line results at week 24. Also, the results were published in Lancet Hematology last month. As you can see, I didn't start from primary endpoint. I started from transfusion independence here. You can see in the red square, the response rate for momelotinib group was higher than for danazol group. 30% versus 20% of patients were transfusion independent at week 24. It is actually impressive how well danazol did, 20%. So this drug certainly has role in management of anemia of myelofibrosis, but obviously momelotinib was better. So the other results, the primary endpoint, the symptoms were controlled in 25% of patients, and splenic reduction by 35% was accomplished in 23% of patients. Certainly, you wouldn't expect much of that happening in danazol arm. So momelotinib did reasonably well from the standpoint of symptoms and spleen size reduction in this group of patients previously treated with ruxolitinib. So the data was then looked at in different subgroups based on platelet count, and it looks like it works as well for patients who have platelet count less than 50, less than 100, or less than 150, with better results in momelotinib-treated patients. So side effects, there were no surprises here. So the grade 3 or higher adverse events happened with similarly in 49 and 46% of patients in momelotinib group and danazol group. The rate of serious adverse events was very similar. So just want to highlight, obviously, cytopenias still occur in myelofibrosis. There are some GI side effects which happened similarly in both groups of patients. And peripheral sensory neuropathy is highlighted at the bottom because there was a signal in early phase studies that may be an issue in momelotinib treated patients, but it didn't really seem to happen in this particular phase 3 trial. Moving on, so from JAK inhibitors to the drugs which have different mechanisms of action and still used in myelofibrosis. And this particular drug is called navitoclax. And in this study, it was used together with ruxolitinib with JAK inhibitor naive patients now. So it's a frontline treatment for patients with myelofibrosis who have intermediate to high risk disease. So, and the study highlights certain things which claim that the results are suggestive of disease modification. Let's look at the navitoclax itself. So what is this drug? So, and why would we combine it with ruxolitinib? So ruxolitinib suppresses transcription through JAK inhibition of JAK-STAT pathway. You can see how it can suppress transcription of pro-survival proteins, MCL1 and BCL-XL. So navitoclax is a direct inhibitor of antipoptotic activity of BCL-XL as well as BCL2. And in preclinical studies, they showed, these two drugs showed synergism in inducing apoptosis in malignant cells. That led to the development of this combination. And at ASH 2022, cohort 3 of REFINE study, phase 2 trial enrolling JAK inhibitor naive patients was presented. So key criteria, key endpoint was splenic volume reduction by 35% at week 24, measured by MRI and CAT scan. And key secondary exploratory endpoints were change in bone marrow fibrosis grade from baseline, reviewed locally, as well as reduction of variant allele frequency for driver mutations determined centrally. So SVR35 was achieved in 80% of patients, which is pretty good. So you can see that pretty much all of the patients had some splenic reduction. And again, among those who accomplished SVR35 response at 24 weeks, about a third of patients had achieved reduction in marrow fibrosis by at least one grade. So the secondary endpoint looked at fibrosis itself. The reduction by 1 grade was observed in 9 out of 32 patients, 28%, and among 9 patients, 2 had complete resolution of myelofibrosis. The mean time to resolution to reduction in bone marrow fibrosis was 12.3 weeks, and also there was significant reduction of JAK2 V617F mutation variant allele frequency. So 36% of patients had 50% reduction or more. So these findings in improvement of fibrosis as well as reduction of variant allele frequency of JAK2 V617 mutation suggest disease modification with use of this medication combination. So next drug, which also was tried in treatment-naive patients, so together with ruxolitinib, is called pelabresib. So this is, again, a phase 2 study. And first of all, a couple of words about pelabresib itself. So it's BET inhibitor, and BET is a family of epigenetic proteins which are overexpressed in cancer. Pelabresib is novel oral BET inhibitor, which belongs to this class of drugs known as epigenetic modifiers. Pelabresib selectively inhibits BD1 and BD2 bromodomains of BET proteins. And you can see on the cartoon on the right that it can work concordantly with JAK inhibitors. So JAK inhibitors inhibits JAK-STAT pathway. BET proteins are important in transcriptions which lead to production of TGF-beta and FKB, BCL2, and c-MYC. Those are associated with aberrant erythroid megakaryocytic differentiation, increased cytokines, bone marrow fibrosis, and cell survival. So if you inhibit JAK as well as BET at the same time, you decrease production of these cytokines, and this can lead to the improvement of symptoms and perhaps disease modification. So the study we're looking at has 4 arms, but we're only looking at arm 3, which is a first-line treatment for patients not exposed to JAK inhibitors who have intermediate to high-risk disease. And all of these people in this phase 2 study received pelabresib and ruxolitinib. The primary endpoint was SVR35, splenic volume reduction by 35%, and total symptom score reduction by 50% at week 24. So as you can see, the SVR35 was at week 24 was 68%. Previous study actually 80%. Again, we cannot compare apples and oranges here. And TSS50 reduction was accomplished by 56% of patients. Interestingly, at any given time, SVR35 was accomplished again by 80% of patients, similar number to which was shown previous study I shared with you. So from the standpoint of bone marrow fibrosis, again, about 27% of patients here had at least 1 grade reduction in bone marrow fibrosis by week 24. Clinical responses were connected to reduction of variant allele frequency in JAK2 V617F mutations. Most adverse events here were low grade, and 14% of patients had to discontinue the study participation due to adverse events. So this is, to me, one of the more exciting presentations, plenary session. You can see this presentation number 6, and it looks at completely different mechanism of action in this group of disease in myeloproliferative neoplasms. So this is the presentation of preclinical data on monoclonal antibody against mutant calreticulin. So mutant calreticulin calreticulin as a protein is responsible for modification of thrombopoietin receptor before it moves to the surface of the cell. And mutated calreticulin, instead of just modifying it, attaches itself to the TPO receptor and moves together with the receptor to the surface, causing dimerization of the receptor and its activation, which doesn't require ligand. So what happens when antibody attacks a mutated calreticulin on the surface of the cell, it reverses this dimerization and activation of JAK-STAT pathway. So this study used fully human Fc-silent IgG1 antibody against mutant calreticulin. The binding was selective to mutant calreticulin, antagonized mutant calreticulin-induced signaling oncogenic function, inhibited cell proliferation, STAT5 phosphorylation, and CD34 mutant calreticulin cells. It caused apoptosis of those cells and didn't affect non-mutant calreticulin cells. Once again, this is the preclinical data. The phase 1 study is expected to be opened within the next few months. So moving on to polycythemia vera, much higher incidence and prevalence of this disease in the United States, only one study. And this is the study for patients with low-risk disease. So low-risk defined as age less than 60 and no history of thrombosis. So these patients historically treated with phlebotomies and aspirin. And what this study looked at is addition of ROPEG interferon alpha 2B to this treatment. So the patients were randomized in this phase 2 trial in one-to-one fashion. Standard of care is on the left, phlebotomy plus aspirin, and on the right is phlebotomy plus aspirin, as well as ROPEG interferon. It's at a fixed dose of 100 micrograms every 2 weeks. Primary endpoint was response, and response was defined as median hematocrit less than 45 in the absence of disease progression. Definition of disease progression for low-risk PV patients includes progressive symptoms and progressive symptomatic thrombocytosis, progressive leukocytosis, vascular, and major bleeding complications. So this is the primary endpoint. The study was published in 2021. So at that time, the second interim analysis was presented at 1 year, and these are final results. So this is observation of patients over a period of 2 years. The study was stopped to accrual after second analysis because significantly better performance of patients who were treated with ROPEG interferon. From the standard of composite primary endpoint, so you can see that this is hematocrit control and lack of progression, which was observed in much higher number of patients treated with ROPEG interferon. So the separate endpoints for hematocrit control and disease progression, you can see that frequency of phlebotomies was less in experimental arm. And you can see that the disease progression was only observed in patients treated with phlebotomies plus aspirin without ROPEG. In 6 patients, platelet count increased to more than 1 million, and baseline was lower than 600. And in 2 patients, splenic infarction and transient ischemic attack occurred. So the effect was reasonably durable, as you can see. And also there was improvement of symptoms as measured by MPN-SAF TSS, and splenomegaly improved in ROPEG-treated patients as well, significantly when compared to patients treated without ROPEG. So JAK2 V617F variant allele frequency decreased in ROPEG-treated patients and slightly increased at 12 months in patients who didn't receive ROPEG. So I'd like to also show the side effect table. Obviously, people who were treated with ROPEG had higher incidence of adverse events. This is included treatment-related adverse events, 55% versus 6%. Grade 3 or 4 adverse events were about the same, and adverse events that caused treatment discontinuation were only revealed in ROPEG-treated patients. In conclusion, I would like to summarize what I presented to you. Momelotinib may improve anemia in patients with myelofibrosis and due to ACVR inhibition. Ruxolitinib and pelabresib, the beta inhibitor and frontline treatment associated with high SVR rates and TSS50 reductions. Decreased fibrosis, declustering of megakaryocytes, and decrease in JAK2 V617F variant allele frequency may be a sign of disease modification. And phase 3 trial, which used the same model of combining ruxolitinib and pelabresib, just completed accrual, so waiting for the results. Ruxolitinib and navitoclax and another combination frontline treatment. This BCL2, BCL-XL inhibitor also was associated with a significant reduction in spleen volume, as well as decrease in fibrosis and JAK2 V617F variant allele frequency. Phase 3 Transform-1 study is ongoing. Monoclonal antibody against mutant calreticulin is effective in preclinical models. We're looking forward to see how this drug will perform in clinical trials. Finally, ROPEG interferon can be considered for selected patients with low-risk polycythemia vera based on the results of phase 2 study.
Thank you, Nikolai. So I'm going to be talking about MDS right now, and let me share my slides. Okay. Okay, thanks everyone. So I decided actually to talk a little bit more in general about some of the main updates on the management of MDS in 2022, integrating some of the ASH abstracts. These are my disclosures. So I'm going to talk about updates in the diagnosis, classification, prognostication, and response assessment, and then management of lower and higher risk MDS. So I think the first important thing to know is that the diagnostic criteria for MDS were updated by the WHO. So right now, rather than requiring a hemoglobin of less than 10 and a platelet count of less than 100, as you can see to the left, the thresholds were a little bit less restrictive. So any anemia, which is hemoglobin less than 12 in women and 13 in men, or thrombocytopenia, platelet count less than 150, can diagnose MDS once you exclude other things that can cause MDS. But importantly, certain genetic alterations such as SF3B1 and TP53.1 could potentially lead to diagnosis of MDS in the right context. So that will probably mean that you are going to see more diagnoses of MDS among your patients. The second, I think, major change in 2022 is the update of the WHO classification. We have two different classifications right now for MDS, WHO 2020 and ICC 2022. And this is important because there are some differences between these two classifications. And you are going to start seeing in your pathology reports some discrepancies between the two diagnoses. In some cases, a patient could be diagnosed with AML by one category and MDS by the other. For the sake of time today, I'm not going to be able to go through the details of this, but the main updates is that certain genetic alteration, as I mentioned, such as SF3B1 and TP53 mutated, now can define genetically MDS, and also the category of 10 to 19% blast in the ICC classification is called MDS/AML. So I think this is important to remember as you look at your path reports. And one of the ASH abstracts actually compared the two classifications. This was a large effort on behalf of the International Consortium for MDS. And I'm not going to go again through all these results, but what was found is that certain aspects of each classification seem to function well. And therefore, ideally, these two classifications should be harmonized, which is an effort that is currently ongoing. But until that happens, feel free to reach out to us and to the pathologist to discuss any aspects of the path report that does confuse you a little bit, because it's going to be a confusing year in terms of the diagnosis and classification. Now going to prognostication, where things are a little bit easier. So we still think about MDS in two big groups, lower risk and higher risk. Lower risk, quality of life is the main goal. Higher risk, you generally would treat with the goal of changing the natural history, often requiring bone marrow transplantation. So this is the classical scoring systems, IPSS and revised IPSS, the two most commonly used ones. And based on the adding of the blast count, cytogenetics, and cytopenias, you classify the patient into these lower and higher risk. One of the main developments of 2022 was the publication of the IPSS-M. So this finally and formally integrated molecular IPSS into the prognostic picture. You can see here on this table a list of the genes. So there are 31 different genes that are part of the molecular classification. And this is becoming the standard of care risk tool assessment. Again, why is that important for your practice? Is now it's having the molecular data affects both the diagnosis, classification, as well as prognostication of MDS. And I still see many path reports or when the workup for MDS is done in community settings, many times people are just sending karyotype and FISH, and they are not sending molecular assessment. So it's really important that a next-gen sequencing, which is readily available in our hempath department, should be run on those patients, because it can affect all of these assessments, which subsequently can influence therapy. The IPSS-M now uses 6 categories rather than 5 categories, 3 lower risk ones and 3 higher risk ones. And the good news is that this got rid of the intermediate IPSS-R, which used to be a problem because it was never clear whether you treat it as lower risk or higher risk. There are different ways to do that. But in the molecular IPSS, the patient is either lower risk or high risk, and I think that makes it somewhat easier. Now, this model is a bit complex, And it's not easy to clearly remember all the different variables, but the good news is that you have this website, mdsriskmodel.com. You can see it to the left side. And all what you need to do is just enter the variables, blast count, age, hemoglobin, platelet count, and what molecular alteration the patient has. And then you can see that the IPSS-M score, for example, for this patient was 0.24, moderate high. Also, this gives you the revised IPSS score. So you can get both the molecular and the revised IPSS in the same snapshot when you enter the data. So one of the important presentations from ASH 2022 was comparing the molecular IPSS, which was just published in 2022, again against the revised IPSS. And what you can see here is that the C index, which is a measure of the prognostic utility or the model accuracy, is better for the molecular IPSS in this large European cohort. There were several presentations looking at this from different cohorts, and all of them showing the same thing, is that the molecular IPSS is better, and therefore I think we should really try to get it calculated on all of our patients. But of course, that's going to require you to get the molecular data. So we talked about diagnosis, classification, prognosis, and the response criteria. Response criteria have been somewhat problematic in MDS because they have contributed to some of the delayed drug development, in my opinion, by introducing data molecular responses that are suboptimal, such as MARO-CR, which has never been correlated with long-term survival, and at the same time used very high cutoff for hemoglobin, for example, of 11 to denote complete response, which is very difficult to obtain in an MDS patient. And this is beyond the scope of discussion today about all the issues that come with the response criteria. But finally, an international panel, the IWG, has revised the criteria. So we have a new criteria for higher risk MDS. And I think this is going to address several of the shortcomings of the 2006 criteria. About some of the clinical development abstracts, there were several important ones for both lower risk and higher risk. For lower risk MDS, the treatment continues to be ESAs, erythropoiesis-stimulating agents, for most patients with lower risk MDS. However, for patients who have deletion 5q, lenalidomide is an important drug. Lenalidomide is currently approved for lower risk deletion 5q MDS patients who are transfusion dependent. So this important abstract, this is a randomized phase 3 trial, looked at giving lenalidomide in patients with del 5q lower risk who are not yet transfusion dependent. As you can see, the criteria eligibility, anemia of less than 12. So if you have a hemoglobin of 10 or 11 and you are symptomatic, even if you are not needing transfusions, you would be eligible for this trial. Patients were randomized to lenalidomide in a time-limited fashion, meaning that you are getting the drug only for 2 years, it's not continuous, versus placebo, and then the patient were monitored. And this is the top-line result of this study, is that lenalidomide has significantly lowered the chance of needing regular transfusions, as well as delayed the time to transfusion dependency significantly, more than 6 years, for patients who are on lenalidomide compared to patients who are getting placebo. And also induced a lot of cytogenetic responses, and the safety profile, both hematological and non-hematological, was generally well tolerated. So I think this could potentially lead to a major change in practice in earlier initiation of lenalidomide. And this is one thing that I think is important to consider in patients with deletion 5q who are anemic but not yet transfusion dependent. The Mendez trial, which many of you have contributed to when it was ongoing, this trial led to the approval of luspatercept, the transforming growth factor pathway drug that is a ligand trap that has been shown in patients with ring sideroblast, MDS with ring sideroblast, to improve transfusion independence. You can see this is a New England Journal of Medicine paper that led to the approval, 38% transfusion independence. We published an update from that study in 2022, showing that the responses with luspatercept were long-lasting and not only limited to transfusion dependence, but there was a lot of improvement in hematologic parameters, as well as significant reduction in the red blood cell transfusion among those who did not fully achieve transfusion independence. However, the approval was after ESA failure for patients who have MDS with ring sideroblast. So the COMMANDS trial, this is a phase 3 trial of luspatercept versus ESA. So this is a frontline treatment where patients were randomized to receive either luspatercept or erythropoietin in the frontline setting, first treatment, and not only in patients with ring sideroblast, but also in patients without ring sideroblast. And this trial was a large international trial, more than 350 patients were enrolled, including here at Yale. Data were not presented from this trial in ASH, but there was a press release from the manufacturer, basically declaring positive results for the primary endpoint. So this is, I think, could be an important development in the management of lower risk MDS in 2023. We are hoping to see the data later this year describing the impact of luspatercept in the frontline setting. Another trial that was open here at Yale is the trial that looked at the imetelstat, which is a first-in-class telomerase inhibitor. This is an IV drug that's given every 4 weeks. And phase 2 data, single-arm phase 2 data previously published have shown that among patients who are heavily transfused without deletion 5q, but had lower risk MDS, 38 patients have high rates of transfusion independence with this drug, 40% achieved transfusion independence. This was previously published. What was presented in ASH is an update on the patients who had transfusion independence on the drug, which lasted more than 1 year, and there were 11 out of the 38, 29%. And you can see here that among those patients, there was significant durability of the transfusion independence, 92 weeks of transfusion independence, but also the mean change in the hemoglobin was quite impressive. The median increase was almost 3 grams. So those are not patients going from hemoglobin 8 to 9. This is someone going from 8 to 11. So that's certainly is a meaningful benefit. But importantly, there was a press release also. This was a year of press releases for lower risk MDS. The Amer phase 3 trial, the top line results also confirmed the advantage of the phase 2, showing transfusion independence with imetelstat in 40% of patients who have received this drug. And this drug is now in front of the FDA, also in consideration for approval. We are hoping to see the data also later this year. But between these two drugs, I think there could be a significant change in the landscape of management of lower risk MDS. About higher risk MDS. So HMAs have been a significant, basically in terms of helping patients with high risk MDS, but real life data such as the one I'm showing you here showed that the benefit from HMAs is suboptimal. The median survival is only 11 to 17 months. Once they stop working, the survival is 5 to 6 months. So we certainly need improvements. However, many of the drugs that were added to HMAs have not, unfortunately, shown any benefit. We have a big graveyard of drugs. You can see some of them listed here that once combined with HMAs, initially they showed good data in single arm trials, but once you have the phase 3 trials or the randomized phase 2 trials, the results were negative. However, we have other drugs that are now in phase 3 trials, and we are optimistic about some of those. You can see here 6 randomized phase 3 trials ongoing in the high risk MDS setting in combination with HMAs. The 2 trials that you see the drug listed in black, pivonidistat and APR-246, unfortunately, those 2 trials have read out as negative for the primary endpoint. But the other 4 trials with venetoclax, sabatolimab, magrolimab, and tamibarotene, all of those are ongoing, and I'm going to tell you a little bit about them. However, none of those 4 trials have yet reported. But I think those are trials that are important for the field, because they potentially, if any of them was positive, it could change the landscape of treatment of high risk MDS. So another important reminder is that patients with MDS should be considered for transplant when they have higher risk disease. If you just keep the patient on HMA alone, the long-term survival is very poor, 4% for high risk MDS patients. And now we have randomized data. This is biological assignment trial. If you have a donor versus no donor, and that showed up to the age of 75 that your overall survival could be doubled. The 3-year survival for patients who had a donor was 50% compared to 26%. And again, this is up to the age of 75. Many patients are being told they are not candidate for transplant because they are late 60s or early 70s. But if the patient is otherwise good shape, I would strongly recommend that you refer them to discuss transplant. Venetoclax is approved for older unfit patients with AML. However, the data in frontline in high-risk MDS has been promising, but this is single-arm trial. We have previously published a trial that Yale participated in the relapse refractory setting where venetoclax has been added after HMA failure. And the Verona trial, which also was open at Yale, randomized patients to receive AZA versus AZA-VEN. This trial has fully accrued, and we are waiting for the results of this trial to look at the role of venetoclax in high-risk MDS. Another, I think, interesting molecule that we've been part of is sabatolimab, anti-TIM3. So TIM3 basically is an inhibitory receptor that is not only present on T cells like regular immune checkpoints, but this is also present on some of the leukemia stem cells and the blasts. So sabatolimab could basically be targeting both the immune system as an immune checkpoint inhibitor, but also directly attacking the blasts and the leukemia stem cells. Early data have suggested activity in the clinical setting. And based on this, a randomized phase 2 trial, which we had open here at Yale, the Stimulus MDS1, randomized patients to receive sabatolimab with HMA versus HMA alone. And the primary endpoint was CR and PFS. We presented this data in ASH. This was the only randomized phase 2 trial presented in ASH 2022. Unfortunately, the primary endpoint on this randomized phase 2 was not reached. There was still no significant difference in CR and PFS, but what I attract your attention to is that there was late separation of the curves, and the PFS was 11 months compared to 8.5 months, which would be potentially consistent with delayed onset of action seen with immune checkpoint inhibitors. And importantly, among patients who achieved CR, so the CR rate was not increased, but those who achieved CR, the duration of the CR was double for the combination compared to HMA monotherapy. Again, suggesting potentially that there could be a deeper response and more durable response with the combination. But of course, these are exploratory analysis. The phase 3 trial is already also fully accrued. It was open at Yale. Some of the care centers have contributed patients to this trial, which randomized patients to receive sabatolimab versus, sabatolimab with HMA versus AZA alone. And this trial is fully accrued, and we are waiting for the results. Magrolimab is another drug that had attracted a lot of attention in AML and MDS. This works on the CD47, the don't eat me signal. CD47 is expressed in MDS cells, and it can evade phagocytosis. So inhibiting it with anti-CD47 agent can lead to increased phagocytosis of blasts and clinical benefit. This is a phase 2 study of magrolimab with azacitidine showing promising responses, but this was a single-arm trial. There are ongoing phase 3 trials with this drug magrolimab. We also have a study coming at Yale where oral HMA is being combined with magrolimab. This is a trial in progress abstract presented in ASH that discusses the design of this trial. And we have another anti-CD47 agent that is being tested for MDS and AML after HMA failure. So a lot of drugs are being tested in MDS. This is showing some of the trials that we had open or are in activation process. The tamiparotene, which is a RARA agonist, super agonist. RARA is basically overexpressed in around half of the patients with MDS. So this is a phase 3 trial that randomizes patients to AZA, tamiparotene versus AZA. This is in activation in addition to the single-arm oral decitabine with magro for higher risk MDS. And then for the lower risk, we have an extension of the imetelstat sub-study that I mentioned to you. So this is a single-arm study that gives patients with imetelstat, and this includes patients with HMA failure or lenalidomide failure. So I encourage you to refer patients who are transfusion dependent, who have not responded or benefited from standard of care drugs. So this is my last slide, and I'm happy to take any questions later. Thank you so much. And
Okay.
Dr. Lourdes will present now updates on acute leukemias.
Okay. So I'm going to start with AML and then move to ALL. I have no disclosures. So AML remains a disease with suboptimal outcomes. The 5-year relative survival is 30.5%. And this is a disease of older adults. Median age at diagnosis is 68, and at death is 73. And so treatments that are efficacious, either new agents or new combinations, particularly that are tolerated by this age group, are needed. The addition of venetoclax to hypomethylating agents improved CR rates to 65 to 70% in the frontline setting in older unfit AML. However, longer-term data from the Yale study has shown that only a minority of patients experience durable remission and survival, such as at 2 years. And in high-risk groups, such as TP53 mutant AML, but also FLT3 mutant AML, particularly in older and unfit AML patients, there continue to be very poor outcomes. As an example, in TP53 mutant AML, the median overall survival is 5 to 7 months with our standard of care therapies. There's also a great need in relapsed refractory AML, where the median overall survival in the unfit subgroup is 3 to 7 months. And so turning to the TP53 mutated group, it is occurring, this mutation, in 5 to 10% of patients with de novo AML, and it's enriched in therapy-related AML. And as noted before with standard of care, the survival is poor, less than 1 year, including post-transplant. And so Dr. Zeidan discussed this agent, magrolimab, which targets CD47, which has been called a myeloid checkpoint, and is a do not eat me signal. And Naval Daver presented results from the phase 1/2 study of the triplet of magrolimab on the venetoclax and azacitidine backbone in newly diagnosed patients with AML, in a group of patients that was heavily enriched for TP53 mutated AML. And so what's being shown here and what was presented was a frontline cohort and separated into de novo AML and secondary AML that was untreated, secondary meaning having antecedent hematologic malignancy that could have been treated, but not with hypomethylating agent. And so you can see the age is older individuals and almost exclusively heavily weighed in terms of being adverse risk group ELN 2017 classification system. And further separated into by the TP53 status, mutant versus wild type. And as I mentioned, heavily enriched for TP53 mutated patients, given that there's hope for magrolimab for this subtype of AML. And these are the response rates, again, separated into the de novo group and the untreated secondary AML group, and separated by the status of TP53 mutation. And so there is CR/CRI rate of 63% with TP53 mutated patients in de novo and untreated secondary, and a higher CR/CRI rate in the wild type patients, ranging from 80 to 90%. And on the left is are the survival curves for the de novo population alone. You can see a separation in the curves between TP53 wild type and TP53 mutant patients. The 12-month overall survival of the TP53 mutant patients was 53%, which compared to historical data is encouraging, because I'll remind you that the median overall survival is on the order of 6 months. On the right is the median overall survival in the combined frontline groups, which is less favorable because the secondary AML patients did not respond as well and had short responses as well. So moving on to a separate high-risk group, the FLT3 mutated group, Nicholas Short reported updated results from a phase 1/2 study of another triplet, gilteritinib added on to the backbone of venetoclax and azacitidine for patients with FLT3 mutated AML. And there were 2 groups of patients, those who were newly diagnosed with FLT3 mutated AML, and this could be ITD or TKD, who were unfit for intensive chemotherapy. And then there was also a relapsed refractory group. And in the middle, you see the schedule of treatment. Notably, with triplets, myelosuppression is a concern. And so built into the treatment schedule is a day 14 marrow that informs the subsequent continuation or not of venetoclax. Gilteritinib was given at 1 of 2 doses, and the recommended phase 2 dose was ultimately selected to be 80 milligrams of gilteritinib. And on the right, you see the consolidation treatment plan. So these are the responses for the frontline and the relapse refractory group. You can see the composite CR rates are quite high, 100% in the frontline group and 70% in the relapse refractory group, and there were no early deaths, and it was considered to be well tolerated. These are the overall, the relapse-free survival on the left and the overall survival curves on the right. And you can see that the 1-year overall survival rate is 85%, which is, again, very encouraging compares favorably with historical results. So I just briefly want to touch on menin inhibitors and the concept behind these drugs. There are several menin inhibitors under development, and the menin KMT2A, previously known as MLL, interaction is a critical dependency in MLL mutated rearranged leukemias, as well as, interestingly, in NPM1 mutated leukemias, where it's responsible for enacting an aberrant leukemogenic gene expression program. So the inhibitors bind a well-defined pocket, and this disrupts the interaction between MLL and menin and causes an abnormal transcription complex to disassemble, and through downregulation of HOX-A and MACE transcription and other targets, allows differentiation of the leukemia cells as well as apoptosis. And so, as I mentioned, there's more than one of these inhibitors that's being developed. Dr. Issa reported results from the phase 1 study of the menin inhibitor revumenib in patients with KMT2A rearranged or NPM1 mutant AML. And for the sake of time, that trial is the Augment 101 trial. And what was notable in terms of adverse events were frequent QTC prolongations, and there were 2 dose-limiting toxicities because of QTC prolongation. But there was lesser rate of grade 3 or more QTC prolongation. And in a heavily pretreated group with a median of 4 prior lines of treatment, there was encouraging activity with 30% CR/CRh, meaning incomplete hematologic recovery rate in these genetic subgroups in MLL rearranged and NPM1 mutated leukemias. And the response rates were different by each genotype. Dr. Harry Erba presented on another menin inhibitor, ziftomenib, in the same type of AML, and also in the relapse refractory setting, the COMET 001 trial. And here, differentiation syndrome was observed, as was with the prior menin inhibitor, but there were no drug-induced QT or QTc prolongations reported. And again, particularly at the 600 milligrams dose, which was the recommended phase 2 dose, there was in heavily pretreated population evidence of encouraging activity with a 30% CR rate. In the NPM1 mutated group, the CR rate was much lower in the MLL group, and it remains to be seen whether, in fact, there's differential activity in different genotypes with these agents. So, in conclusion, for this AML section, menin inhibitors are showing promising activities in relapsed NPM1 and MLL rearranged or mutated patients, and the two triplets that I touched on with gilteritinib on a backbone of azacitidine and venetoclax, also showing promising safety and efficacy in the upfront, but also relapse setting, whereas magrolimab added to azacitidine and venetoclax shows promising activity in TP53 mutated AMLs, and there are randomized trials ongoing for magrolimab. So turning to ALL, ALL is evenly split between the pediatric and the adult groups, roughly half and half. However, whereas the median age at diagnosis is 17, the median age at death is 58. And so the outcomes are far inferior in adults. And this is a particular problem in older adults. And here you see a summary of overall survival at the 3 and 5 year marks, which on average is about 20%. And if you consider individuals that are elderly, 70 or above, they're really dismal rates and outcomes. And just as a kind of a reminder of the importance of measurable residual disease in ALL, the two outcomes, event-free survival and overall survival, you see a dramatic split between those patients who have no measurable residual disease and those who do. But importantly, there's also relapse and mortality even in the situation of no measurable residual disease. And so one of the strategies that's been taken to try and improve outcomes, particularly in older adults, is the integration of novel agents into the frontline setting, focusing on blinatumomab and inotuzumab. Inotuzumab is an antibody drug conjugate against CD22. Blinatumomab is a bifunctional T-cell engaging antibody that directs cytotoxic T-cells to CD19 expressing cells. And notably, the trials that led to the approval of blinatumomab and inotuzumab in relapse refractory B-ALL demonstrated that inotuzumab has activity across all levels of disease burden, suggesting that it could be suitable for induction, whereas blinatumomab has higher efficacy with lower burden of disease, suggesting that its role may be primarily in a setting where there's already been cytoreduction. So there's multiple trials that are studying the combinations of inotuzumab with chemotherapy, particularly in older individuals. And this is the GMAL Initial 1 trial. And in this trial, it's a sequential strategy. Inotuzumab is given for 3 cycles, followed by conventional chemotherapy in patients greater than 55 years of age. In this trial, the primary endpoint was 12-month event-free survival with a goal of seeing better than 60%. And you can see on the left that this was met at 1 year, it was 88%, and at 2 years, it was 73%. What you'll also note, though, is the downward slope of this curve indicating that there are ongoing events after year 1, suggesting that there may be a need to improve the consolidation strategy. There was a similar in terms of approach study that was presented by Chevalier, the results of the EWAL-INO study. And here, inotuzumab is intercalated with chemotherapy from the beginning. and these are only two of a number of such studies. The presentation that perhaps received the most notoriety at ASH 2022 was in the space of ALL, was by Mark Litso, reporting the results of E1910, a phase 3 randomized trial of blinatumomab for newly diagnosed Ph-negative B-ALL in adults. And these adults were ages ranging from 30 to 70, and they received 2 cycles of induction, intensification, and were then randomized either to the experimental arm or to the standard consolidation chemotherapy arm. The experimental arm had 4 cycles of blinatumomab intercalated with chemotherapy consolidation. MRD, of course, was actually the outcomes in MRD negative patients was the focus of the study, and MRD was defined as greater than or equal to 1 in 10,000 cells as assessed by 6-color flow cytometry. And so these are the results. This is overall survival in MRD negative patients, and you can see a very clear survival advantage with the addition of blinatumomab. The median overall survival is 71 months with chemotherapy alone, and with the addition of blinatumomab is not reached. And so this is a landmark study, and showed for the first time a benefit of blinatumomab in MRD negative patients. I'm not showing here, but MRD positive patients, there's also a separation in the curves that did not reach statistical significance, and it's unclear if this is due to smaller numbers or for other reasons. So very briefly, for Ph positive ALL, Nicholas Short presented for upfront treatment, the combination of ponatinib and blinatumomab. And here, the rationale is that with second-generation tyrosine kinase inhibitors, the majority of patients will relapse with T315I mutated BCR-ABL, which ponatinib is active against. And in Ph-positive ALL, chemotherapy-free induction has been pioneered with publications on dasatinib and prednisone, ponatinib and prednisone, and the D-ALBA trial reporting dasatinib and blinatumomab. And just very briefly, there are very striking results in 40 patients in the frontline setting, CR/CRI rates of 96%, complete molecular response of 87%, with an equally striking event-free survival and overall survival curves with a median follow-up of 18 months, with the 2-year overall survival being 95%. So in summary, for the abstract shown for ALL, inotuzumab is an effective induction agent with acceptable low toxicity and promising early survival outcomes. In the late-breaking abstract presented by Dr. Litso, the addition of blinatumomab to chemotherapy consolidation in adult patients with MRD negative B-ALL has shown for the first time an overall and relapse-free survival in a randomized study. And so blinatumomab as a part of post-remission therapy represents a new standard of care for this group of patients. And one of the challenges in the field will be how to incorporate this in regimens in addition to E1910, since that is not too frequently used. And the combination of ponatinib and blinatumomab is a promising chemotherapy-free, potentially transplant-sparing regimen for Ph-positive ALL.
All right, so we are open for questions. Please go ahead. We will stay a few minutes late if necessary. I know it's end of the hour already. Any questions?
I probably can ask a question while we are waiting for people, like to Dr. Mendez. So for ALL treatment, do you foresee moving away to chemo-free regimens, even in younger patients in the near future? Clearly, the progress has been quite impressive with those novel agents.
I think so, especially, I mean, one of the hesitancies in terms of bringing ponatinib to the front line is its toxicity profile, which I didn't have a chance to discuss. And the concern for that would be less in younger patients. And the efficacy, at least that we're seeing, is so high that I think that would be a reasonable approach. I think especially, I mean, in combination with blinatumomab. So one can envision a chemotherapy-free approach there. And I think the difficult question is the role of stem cell transplant. And we need longer, more mature data to guide us on that.
There is a question in the chat. I think it's to you. Oh, yes, no, it's to Lourdes.
To the MAB drug substitute of chemotherapy in ALL or AML?
So I guess, any of those drugs which, will lead to chemotherapy-free.
Like a blinatumomab, inotuzumab, magrolimab, the anti-monoclonal.
Yes.
Oh, so it's a similar question about chemotherapy-free treatment of ALL and AML.
How about AML?
In AML, that's an interesting question. And I took notice of a comment by Naval Daver, who was saying that there's going to be a trial exploring magrolimab and a drug I didn't have a chance to touch on, which is, I think, now been given the name Pivoke. You could correct me if either of you knows how to pronounce that.
Yeah, it's an antibody drug conjugate against
CD123. For
CD123. The name I don't know.
But for CD123. And so that's going to be something that we're going to explore. I think chemotherapy-free, there's other possibilities, sorry. If we talk about TKIs and venetoclax, those are other possibilities as well. But I think there's a lot of hope in the triplets. And I don't know if anyone would comment more on terms of
I actually have
AML.
I actually have a question to Amer. So there was nothing mentioned about immunotherapy in this malignancies, so in myeloid malignancies today. So what do you think is the role of immunotherapy in this group of patients?
Yeah, I mean, I talked a little bit about sabatolimab and magrolimab. I mean, I think as immune checkpoint inhibitors, I would put them in that category. But I think the other drugs we did not mention or approaches were CAR T cells as well as bispecific. So the CAR T cells are going to be covered by the cell therapy talk, which I think is later in this series. However, in the myeloid space, both of those approaches have been quite challenging, mostly because of cytokine release syndrome and prolonged cytopenias. B cells you can ablate as much as you can without, and you can live with no immunoglobulins generally, okay? But in myeloid space, it has been a very difficult development. So it remains to be seen. There are some phase 1 trials that are going both with CAR T cells and bispecifics, but this particular area, I think, has struggled a lot. The antibody drug conjugates, and you could debate whether this is immunotherapy or not. I tend to think of them more as targeted delivery of agents rather than immunotherapy. I think there is more progress. We clearly have gemtuzumab ozogamicin already approved, and then the CD123 agent that Dr. Mendez mentioned. And in the transplant session, which I encourage everybody to attend, there is this IUMAB drug. There was just a couple of days presentation in the tandem transplant meetings. This is a radioimmunoconjugate, so it's radioactive iodine conjugated to CD45. And there was an improvement in overall survival when it's given as part of the conditioning for transplant. So there is some movement with the ADCs, but BiTEs and CAR T cells for myeloid malignancies have been a bit of a challenge.
Yep. Thank you, Amer. So I think we're going to wrap it up. Hematology tumor board is coming up, so I have to say goodbye to everyone. And if you guys have any questions, you can certainly email us and contact us after this meeting.
Thank you.
Thank you.
Thank you, everyone.